Hello and welcome to MK's Exam Secrets. My name is Dr. Moses Kazevo, Season 1, Episode 1. This is a series on my YouTube channel where we look at 6 exam questions in one clinical course, and we aim to tackle each question with so much dexterity such that you will be able to ace your exams. If you haven't yet subscribed to the channel, please subscribe to the channel, drop a like, drop a comment, grab your piece of paper, and let's go. So, beginning with question 1. So, you have a 32-year-old HIV positive female, known to be non-adherent to her treatment regimen, presents to the hospital with a complaint of new onset headaches. Her vital signs are only significant for a low-grade fever. Neurological examination reveals right-sided upper motor neuron signs, as well as inattention and difficulty with concentration. A CT of the patient shows ring-enhancing lesions. And then question A says her CD4 count is noted to be 78 cells per cubic millimeter of blood. What differentials would you consider in this patient? 3 marks. So you get a patient that's 32, that's HIV positive. And of course, this woman is not really compliant to her treatment. So you're obviously thinking that this woman has probably an opportunistic infection, given that her CD4 count is very low. In addition to this woman is showing some focal neurological signs where we see the right-sided upper motor neuron signs, as well as inattention and difficulty with concentration. And of course, our CT further confirms that you have the ring-enhancing lesions there, which almost always gives you the diagnosis. So the differentials that I may consider from most likely to least likely, number 1 on the list would obviously be my CNS toxoplasmosis. As you know that with the CD4 count that's less than 200, that's where these opportunistic infections tend to creep in, and one of them being toxoplasma. Then my second differential, of course, would be TB meningitis, because it's very common in HIV patients. Then you may also have cryptococcal meningitis in this case, and last but not least, a pyogenic cerebral abscess. So those are some of the things that I would consider given this presentation that this woman has had of these new onset headaches, the low-grade fever. So you're thinking something that's more or less chronic. And given the HIV status, you're thinking something that is an opportunistic infection. So what is the most likely diagnosis? So this woman most likely has CNS toxoplasmosis. That would explain the focal neurological signs. And of course, that would explain the ring-enhancing lesions. And given the HIV status, the non-compliancy, the headaches, and the low CD4 count. So this woman most likely has CNS toxoplasmosis. What diagnostic serological test are you going to order? So you want to order for a serological examination. So you want to check for IgM and IgG against toxoplasmosis, a test that is known as the Sabine-Feldman dye test. So you can do the Sabine-Feldman dye test as a diagnostic investigation in this case. And what other tests will you do in this patient? So remember that here they've already done your CD4 count. So you may alternatively go and do your viral load for this patient to see the extent of viremia that may be there. You also want to do a lumbar puncture, though that wouldn't be top on my list because this woman is showing you some signs of focal neurological signs. And so you may do a lumbar puncture given if there are no obvious signs of intracranial pressure. So you may do your lumbar puncture and get your CSF4 microscopy culture sensitivity. You may also get your CSF4 PCR. You may take what is known as a cryptococcal antigen test, which can be done on the CSF and the serum to check for cryptococcal neoformans. You may also do a gene expert on your CSF to check for TB, which is a form of PCR. You may also want to do a complete blood count or a full blood count, urea and electrolytes, liver function tests, and serum glucose as supportive measures in this patient. Then how can one get the condition? So the infection usually arises when someone ingests oocysts. Remember that these oocysts are found in the soil. They can be found in contaminated water with cat feces, and sometimes they can be through the ingestion of tissue cysts from undercooked meat, or it could be vertical transmission from mother to child. So those are the ways in which this can be transmitted. So it means that the cats are very important in the life cycle of the condition. So eliminate the cats, eliminate the mice, which the cats eat, then Problem solved. And remember that this is a very, very big issue, especially in pregnant women. So you do not want pregnant women handling with cat litter boxes or cleaning cat poop. So what should one do to prevent this condition? So number one, cook your meat thoroughly. This ensures that you kill all the cysts. Number two, so pregnant women should not be allowed to handle cats, should not be allowed to clean litter boxes for cats, and should avoid should avoid eating undercooked meat. In addition to this, please do not feed your cat any raw meat and use cat food for your cats, and don't allow them to feed on the mice that may be running around your house, even though that's what cats may be for, by mouse traps. Anyways, so that's how you would answer a question such as this. So you'd make sure that you have the right details and you understand the question, because that's the basic principle, and that's the basic way of you answering, or the basic fundamental thing that you need to do in order to answer a question adequately. So moving on to question 2. A 36-year-old obese female presents to the primary care physician complaining of blurry vision and increased fatigue. Aside from obesity, her past medical history includes multiple candida infections in the past 6 months. Her physician sends for her laboratory testing with the following results. So a hemoglobin of 12 grams per deciliter, a glucose tolerance test of 202 milligrams per deciliter at 2 hours is above the normal range, the sodium of 137 milliequivalents per liter, potassium of 4.1 milliequivalents per liter, and the creatinine of 0.9 milligrams per deciliter. So what is your diagnosis? So of course, this is a woman that's coming in that's 36. This woman is overweight, so she's obese, and she's having blurry vision, increased fatigue. Okay, so maybe you're thinking something CNS, but I highly doubt that, because there would be other symptoms. Then, apart from the obesity, she's had multiple candida infections. And remember, candida, whenever you see someone having these recurrent candida infections, if it's not really a hygiene problem, then you should think that this is an immune system problem. And what could impair the immune system? Could it be that this person is HIV positive? Could it be that this person has a malignancy? Could it be that this person has diabetes? So let's move on and see what the question goes on to say. So the important part that I want to highlight is this glucose tolerance test that is above normal after 2 hours. Remember how you do a glucose tolerance test. If you haven't yet watched the video on diabetes, please go through the playlist and watch the video after you're done with this. So most likely that this woman has diabetes mellitus. So she probably has type 2 diabetes mellitus with borderline anemia, or you could say she has anemia. So type 2 diabetes with anemia. Then give a brief pathophysiology of your diagnosis. So the reason why I'm going for type 2 diabetes as opposed to type 1 diabetes, remember there are two types of diabetes predominantly, type 1 and type 2. Type 1 is much more common in the younger individuals, and individuals tend to be on the slim side. Then type 2 is more common in the older individuals who tend to be on the obese side. So now the underlying key thing here is the obesity that's there. Remember that in obese patients, they have an increase in the production of non-esterified fatty acids. And these non-esterified fatty acids are the ones that are actually leading to resistance of the organs to insulin, the peripheral organs to insulin. Remember that insulin is produced by the beta cells of the pancreas, and this insulin is released into the blood, and it's supposed to work on certain muscles. Insulin works on the liver, it works on the skeletal muscles, it also works on the adipose. So there is an insulin receptor on these cells that this insulin has to bind. And as long as this insulin receptor is sensitive to insulin, then insulin will carry out its functions. But sometimes there may be some things that may change in the body that may reduce the sensitivity of this receptor. So this increase in non-esterified fatty acids is going to lead to resistance of the peripheral organs, which is obviously going to lead to increased gluconeogenesis in the liver. And this is going to be a decreased peripheral uptake and utilization of glucose by the muscles, because the insulin receptor is not really sensitive to the insulin. And initially, the pancreas is going to sense this, and it's going to respond by increase or producing more insulin. Think of it like this. If you have a company and your company is not producing enough goods, you would push them to make more goods. So the the pancreas pushes itself to make more insulin. So there's a period of hypersecretion of insulin by the beta cells in order to overcome this resistance. But later on, this compensatory mechanism also fails and to respond to the level of insulin. And then you get to see that there's a decrease in the number of beta cells in the pancreas, and amyloid begins to deposit in the islets of Langerhans. And of course, this is what leads to the relative insulin deficiency that we see in type 2 diabetes. Not only the peripheral resistance to insulin, but as well as the relative deficiency of insulin. So list complications of your diagnosis. Remember that diabetes has acute complications and chronic complications. So the acute complications include hypoglycemia, which may obviously be due to treatment. The second acute complication is what is known as hyperglycemic hyperosmolar state, where there is a very high blood glucose level. But then in this case, you do not have ketones like in diabetic ketoacidosis because you have some insulin that impedes or stops the process of ketogenesis. Then the chronic complications, remember that diabetes can affect the cardiovascular system, so it can cause atherosclerosis, it can cause ischemic heart disease, it can lead to hypertension, it can lead to strokes. It may also affect the eyes, leading to diabetic retinopathy. You should know the grading, by the way. It can lead to diabetic neuropathy, which is actually one of the most common complications, and it can lead to diabetic nephropathy, among other things such as diabetic foot ulcers and recurrent fungal infections, oral candidiasis, as well as vaginal candidiasis, which is also known as monliasis. This is obviously what this woman has, the multiple candida infections. So this plays in well with type 2 diabetes. So what is the most common cause of death in patients with this diagnosis? So cardiovascular diseases are the most common causes of death. So people often die from ischemic heart disease. So question 3, a 60-year-old man presents to his cardiologist for worsening shortness of breath and easy fatigability. He began developing symptoms a few months prior to presentation. His shortness of breath is most significant with exertion, and he notes having swollen feet. His medical history includes hypertension, hyperlipidemia, alcohol use disorder. He currently takes hydrochlorothiazide and atorvastatin. On examination, an S3 heart sound and a systolic regurgitant murmur is appreciated on cardiac auscultation. An echocardiogram shows markedly dilated ventricles with reduced ejection fraction. So part A, what is the diagnosis? Part B, what is the possible cause of your diagnosis in this patient? Part C, what is the pathogenesis of your diagnosis? So most likely, if we look at the symptoms that this person has worsening shortness of breath. Whenever you get shortness of breath, you should think that this probably could be a CVS problem rather, or a respiratory problem. So let's go on. And they talk about easy fatigability, which may also fall within either system. Then they talk about it being more significant with exertion. That means we should now lean more towards it being a cardiovascular problem than it being a respiratory problem. And also, it's also played into with the swollen feet and the S3 heart sound and the regurgitate murmur. So there could be something that's wrong with the heart. And they have already told you that on echo, there is markedly dilated ventricles with reduced ejection fraction. So obviously, this is pointing you towards this person's heart failing. So obviously, this person here has biventricular heart failure with reduced ejection fraction. So the reason why I am going for biventricular heart failure, remember that the heart failure could be right-sided heart failure, left-sided heart failure, or biventricular heart failure. So with left-sided heart failure, remember that the blood is being pumped to the body and it's coming from the lungs. So the hallmark of these conditions is going to be pulmonary congestion. So they're going to be features of pulmonary congestion, the shortness of breath, the orthopnea that may be there. Then with right-sided heart failure, it's backing up and going back to the systemic circulation, where there's going to be increase in hydrostatic pressure in the systemic circulation, and there's going to be fluid accumulating in the system. So it means that this is going to be leading to peripheral edema, of which he has swelling of the feet. So he obviously has features of both right-sided heart failure and features of left-sided heart failure. And of course, the S3 heart sound is heard in right-sided heart failure, and the reduced ejection fraction is also seen. So cardiologists now are advocating for you to make a diagnosis of heart failure and state whether it's with reduced ejection fraction or preserved ejection fraction. So you can classify heart failure as heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. Then what is the possible cause of your diagnosis in this patient? So remember that this patient has a history of hypertension. So the heart failure could be due to hypertensive heart disease. This person also has a history of alcohol use and their ventricles are markedly dilated. So obviously this could be alcoholic induced dilated cardiomyopathies, because remember, cardiomyopathies may also cause heart failure. They're not really asking you what are the causes of heart failure in general, but they want you to limit your causes to the particular patient. So please take note of that, especially when you're answering your questions. Don't generalize when they mention that it's in reference to the patient that's being asked about. Then what is the pathogenesis of your diagnosis? So remember that congestive heart failure is very commonly due to either hypertensive heart disease, myocardial infarction, or cardiomyopathies. Whatever the cause may be, there is an impairment of the heart's ability to function as a pump. And because there's this impairment of the heart's ability to function as a pump, this reduces the blood flow that's coming out of the heart, and therefore the metabolic and the oxygen demands of the body are not met. So it means that there's going to be a drop in the cardiac output. There's going to be a drop in the perfusion of the kidneys. And remember that whenever the kidneys are being underperfused, this is going to lead to renin being produced. And renin is going to be released into the blood. That's going to catalyze the conversion of angiotensinogen, which is a protein that is produced by the liver, into angiotensin 1. Angiotensin 1 is going to be converted into angiotensin 2 by an enzyme that's known as angiotensin converting enzyme, which is found in large concentration in the pulmonary vasculature. So angiotensin 2 is the active compound of this system, so it can cause vasoconstriction in order to increase the blood pressure. So if you constrict the venous side, there's going to be an increase in the venous return, there's going to be an increase in the preload, so it means that the heart is going to be stretched out. And according to the Frank-Starling phenomenon, the more you stretch out the heart within physiological limit, the harder it's going to contract and the more blood is going to push out. Then on the other side, you're going to constrict the arterioles. So it means that the heart has to generate a greater force to overcome this resistance. So it means that this is good for someone who had a blood pressure that was falling. In addition to this, the aldosterone is also going to be released from the zona glomerulosa of the adrenal adrenal cortex, and this aldosterone is going to cause the reabsorption of sodium in the kidneys. In addition to this, ADH, not adrenaline, ADH or vasopressin is also going to be released from the posterior pituitary gland to enhance the reabsorption of water via the aquaporin 2 channels. So all these things are going to be playing together in order to increase the blood pressure and to compensate for this fall in the cardiac output and the underperfusion of the kidneys. So it means that the heart now is going to be working much harder, it's going to be beating much faster, and it's going to require oxygen because the heart itself also requires oxygen. And because now this heart is not receiving enough oxygen, then these compensatory mechanisms that were initially saving or increasing the cardiac output to some extent begin to harm the heart. So the heart gets from a compensated state to a decompensated state, where now these things that were increasing the vascular tone, increasing the afterload, increasing the preload, all these things are now putting strain on the heart, and the strain that's going to be there is going to be leading to cardiac remodeling, where the heart is going to be moving from a phase of hypertrophy and then eventually leads to dilatation, and then eventually the heart will be failing to, of course, pump and push out the blood. So that's pretty much a summary of what's happening in heart failure. And this is obviously due to the sympathomimetics, or the sympathetics rather, that are there, that are working to increase the heart rate, to cause the vasoconstriction as well, among those things. Then you may also get these features, like I told you, with right-sided heart failure and left-sided heart failure, which I already explained in part A of the question, or rather, part A of the question. So we move on to question 4. A 55-year-old man presents to the emergency department for difficulty in difficulty with speech, and weakness in the right upper extremity. He was last known to be neurologically normal 2 hours prior to presentation. He has a medical history of atrial fibrillation, hypertension, hyperlipidemia, and type 2 diabetes mellitus. He smokes approximately 1 pack of cigarettes daily for the past 15 years. Physical examination is notable for 2 out of 5 power in the right upper extremity and word finding difficulty. So what is your next step in attending to this patient? So this is a patient that's come in 55 and they can't speak properly and they have weakness on the right upper extremity. And this person was last neurologically normal about 2 hours prior to the presentation. And they are going to have a medical history of atrial fibrillation, hypertension, hyperlipidemia, and type 2 diabetes. So when you think of this, you're thinking, okay, this person may have a problem with their brain. And what could cause them to present with weakness in the upper limb and a problem with their speech? So if there's a problem with their speech, it means that their Broca's area is affected and the motor area is affected. So most likely that this person may have a stroke. Okay, so the next step that you do in attending to this patient is, of course, admit this patient and order for an urgent CT scan without contrast or an MRI of the head. So an imaging test showed no intracranial hemorrhage. What is your diagnosis? So obviously this person has an ischemic stroke and you have to rule out a transient ischemic attack after 24 hours because sometimes these may resolve in 24 hours. But the rule of thumb is that if they do not resolve within the first hour, they are most likely not going to resolve. Okay. So give the pathogenesis of your condition. So remember that stroke could either be due to thrombotic or embolic phenomenon. So the thrombotic phenomenon is often due to stenosis of a critical vessel. So there's some local atrial obstruction that happens. And this is usually associated with atherosclerosis, but it may also be associated with other conditions such as fibromuscular dysplasia. And on the other hand, with embolic phenomenon, you have some cardiac emboli that may be arising from the heart, obviously in this case due to the atrial fibrillation, or thromboembolic phenomenon where you have dislodging of a thrombus, and it occurs when an extracranial thrombus is actually dislodged, it embolizes, and it goes and occludes one of the large intracranial arteries. So whatever the mechanism it may be, there is going to be diminished blood supply to the area of the brain which is supplied by that vessel. And this is going to lead to ischemia of this affected territory, and the features that this territory controls are going to bring about the characteristic symptoms that are seen in the patient. Like, for example, in this case, the motor area is affected as well as the Broca's area in this case. Then part D, list investigations you would carry out in this patient. So we've already ordered for a CT scan of the head. So please do an ECG in view of this person having atrial fibrillation, hypertension, do a Doppler ultrasound, or you could do an MRI of the extracranial carotid arteries, do a full blood count, order for an HIV test, do serum creatinine and urea, do a lipid profile in view of the hyperlipidemia that may be there, that history, do serum glucose and electrolytes, also order for a clotting panel, so order for your prothrombin time, your partial thromboplastin time, and your INR, because this patient obviously is going to be needing some medication, antithrombotic agents. Then moving on to question 5, Mrs. Daka has just been admitted to adult medical emergency ward with 1 month progressive worsening shortness of breath and swelling of feet. She explains that lately her heart has been beating faster than usual. Furthermore, she explained that she becomes very breathless when she tries to lay flat on her bed. Physical examination reveals that she has an irregular pulse of 154 breaths per minute. Her heart rate was 176 beats per minute and irregular. Her blood pressure was 138/76 beats per minute. She has a mid-diastolic murmur at the mitral area, best heard with the bell of the stethoscope. So what is the most likely diagnosis here? So let's see what we're trying to do here. So we have a patient that's admitted to the adult medical emergency unit, and they are having this progressive worsening shortness of breath that's happening over a month, and they are having swelling of the feet. And of course, this woman comes in and she is complaining of her heart beating faster than usual. So obviously she has a palpitation and a tachycardia. Then she becomes very breathless when she lies flat on the bed, so you refer to that as orthopnea. And her pulse is irregularly irregular. So that's a hint that you've been given there. And 154 beats per minute, and her heart rate is 176 beats per minute, and also irregularly irregular. And of course, her blood pressure is 138/76. She also has a mid-diastolic murmur that's best heard at the mitral area with the bell of the stethoscope. So this irregularly irregular pulse is obviously pointing you towards atrial fibrillation. So this woman most likely has atrial fibrillation, and the fact that she has these features of heart failure that we may have talked about in the previous question. So it could be atrial fibrillation and biventricular heart failure secondary to mitral stenosis, because this murmur that you hear of a mid-diastolic murmur at the mitral area is most likely consistent with mitral stenosis. And obviously, because this woman is having these symptoms at rest, you would put her at New York Heart Classification, Class 4. You should actually know how to classify the different stages or the different classes of heart failure. So explain why Mrs. Darker's heart rate and pulse rate are different. So most likely, this is due to her heart being in fibrillation. So the atrial beat is usually more frequent than the ventricular beat. And only every second beat is actually seen to get through to the ventricles. Therefore, if you're getting this blood being pumped out of the heart, it will be at a much slower rate than the heart is actually beating itself. And this is what's actually contributing to the discrepancy that you can see between the heart rate and the pulse rate. It's because the heart will be beating faster and not all the impulses from the atrium are reaching the ventricles. Therefore, the rate at which the blood is being pushed out of the heart is not the same as the rate at which the heart is beating. Hence the differences. List 5 causes of atrial fibrillation. So you could classify them as pulmonary causes, things like pulmonary embolism, pleural effusions, lung cancers, pneumonias, even COPDs. Or they could be cardiac causes such as ischemic heart disease, especially acute myocardial infarction, hypertension, heart failure, cardiomyopathies, pericardial diseases, myxomas. You could also have rheumatic valve disease. You could also have mitral stenosis, as in this case. Then you could have toxic or metabolic causes, things like thyrotoxicosis, alcohol itself. You could have some electrolyte imbalances, such as hypokalemia, hypomagnesemia. You could also have diabetes and, of course, sepsis. Then briefly explain the mechanism of atrial fibrillation. So the pathogenesis of atrial fibrillation is now thought to involve the interaction between initiating triggers, which are often these rapidly firing ectopic foci that are present and are located inside one or even more pulmonary veins. So you have these ectopic focus or foci that are initially triggered, and once you have this, then you also have an abnormal atrial tissue substrate that's capable of maintaining this arrhythmia. So those are the two things that have been implicated. You have this ectopic foci that is found in one or more of the pulmonary veins that is being initially triggered, and of course, this abnormal tissue that are conducting within the heart. Then list 2 complications of atrial fibrillation. So you could have thromboembolic phenomenon, you could have strokes, you could have acute heart failure, you could have pulmonary edema. Then list 5 investigations you may carry out in a patient with atrial fibrillation. So you want to do an ECG, you want to do an echo, you also want to do a chest x-ray. You want to do thyroid function tests because hyperthyroidism can cause atrial fibrillation. You also want to do urea and electrolytes, and if you so wish, you may also do a full blood count or a complete blood count. So the doctor decides to control the patient's heart rate with digoxin. He is, however, concerned that the patient might develop digoxin toxicity. Name one test you would do as a precaution to avoid digoxin toxicity. So you'd obviously want to do your renal function test because it's being excreted via the kidneys. List 3 symptoms of digoxin toxicity. So patients usually get this yellowing of the vision, which we call xanthopsia. They may also have blurring of their vision. They may have nausea and vomiting. They may have dizziness, they may have palpitations, they may have bradycardia. So you can just pick any 3 of those. But the xanthopsia and the blurry vision must be there. The yellowing of the vision and the blurring vision of the vision must be there. And name the antidote. So we usually give digoxin immune antibodies. Okay, so you give this digoxin immune antibodies. That's the antidote usually for digoxin toxicity. So the last question 6, and if you're enjoying these videos, please leave a like, leave a comment, and subscribe to the channel. So last question is: a 72-year-old homeless man has been feeling unwell for the past 5 weeks with fever and a productive cough. His fellow homeless men have brought him to the emergency medical unit or house suite. They say he has lost more than 10% of the weight over the past 2 months. Examination reveals he is confused, tachypnic, with a respiratory rate of 36 breaths per minute. His blood pressure is 80/50 millimeters of mercury. You order a chest x-ray and you find that he has infiltrates on the upper and middle lobes on the right side. HIV test is negative. So you get a man that's 72, homeless of course, for the past 5 weeks, has been having a fever and a productive cough. Also has been having some weight loss. And the chest x-ray has shown you that there are some infiltrates in the upper and the middle lobes, and he is HIV negative. Okay, so what is your diagnosis? Obviously, this patient has a severe pneumonia. The reason why we have a pneumonia, we have the triad: cough, fever, okay? We don't really see if there's any chest pains that have been mentioned in this. Okay, and of course you have your features on the x-ray. So this man has a severe pneumonia. Okay, then what are the markers of severity in this patient? So this patient is over 65, so they're 72. Excuse me. So this patient has an age of over 65, so they are 72. So that's one risk factor, their age. This person is confused. That's another risk factor. Their respiratory rate is greater than 30 beats per minute. That's greater than 36. That's a risk factor. They are hypotensive, meaning that their systolic blood pressure is less than 90. Their diastolic blood pressure is less than 60. That's another risk factor. And of course, the weight loss that's greater than 10%. So if you're following your CURB 65 score, so your confusion, urea, which isn't yet done, your respiratory rate, blood pressure, and the age above 65. So mention 5 complications of this condition. So the complications may be respiratory failure, which is a pulmonary complication, sepsis and septic shock. You may have uncomplicated parapneumonic effusions that may be there, plural of course. You may have empyema that may be there, and you may also have lung abscesses. So sputum is sent for GeneXpert, and the report shows MTB, which is Mycobacterium tuberculosis detected, medium, rifampicin resistance not detected. You decide to start him on first-line TB medication. List the names of the drugs you will prescribe and 2 common side effects of each drug. So the 4 drugs, remember: RIPE, rifampicin, isoniazid, pyrazinamide, and ethambutol. So rifampicin, one of the side effects is that it causes orange or pinkish or sometimes red discoloration of the body fluids. Their tears may change, their saliva may change, their sweat may change, their urine may change. It may also lead to hepatotoxicity, so it causes some hepatitis. Isoniazid is also hepatotoxic. It can also cause sideroblastic anemia. And one of the other side effects is peripheral neuropathy, which is why it's given with pyridoxine. Then pyrazinamide causes hepatotoxicity as well and leads also to hyperuricemia, so it may exacerbate gout. Then last but not least, ethambutol causes optic neuritis. It may also lead to arthralgia. So that's how you tackle questions. And thank you for tuning into this episode of MK's Exam Secret.